The TRITON trial was a Phase IIb study presented here at ASCO by Dr. Skoulidis, and it compared first-line Durvalumab plus chemotherapy versus Pembrolizumab plus chemotherapy for patients with non-small cell lung cancer having KRAS-mutant or KEAP1 mutations. And this is a population that is relevant to study because there were some previous studies by Dr. Skoulidis and also our collaborator Dana-Farber MSK that show that patients with STK11 or KEAP1 mutation, they can have poor prognosis with immunotherapies, and even some patients with KRAS mutation, particularly due to the mutant allele, can have poor outcomes with immunotherapy. So this is for sure a population that needs better options, and the dual immune checkpoint blockade with Durvalumab and Tremelimumab, so PD-L1 and a CTLA-4 inhibitor can provide, maybe can add some benefit. And this trial show that I think the most important finding is that there was a numerically higher objective response rate with the dual immune checkpoint inhibition, but most important finding I think was that 100% of patients, so all the patients who responded were still responding after 6 months with Durvalumab plus Tremelimumab plus chemotherapy versus 58% of patients in the Pembrolizumab plus chemotherapy arm. And I found this result interesting because there was a meta-analysis published last year by our group and also Dr. Skoulidis as a collaborator. This was a meta-analysis of 6 randomized clinical trials, and we compared dual versus single immune checkpoint blockade in non-small cell lung cancer. And what we show is that patients with STK11 mutation and those who were PD-L1 negative derived improved overall survival. But the effect, especially in the PD-L1 negative population, was long-term. So the curves were mostly overlapping for the first years since randomization, and then they were separated in favoring the dual immune checkpoint blockade arm, with nearly doubled overall survival rates at 5 years. So we've seen this kind of long-term benefit in the meta-analysis. This seems to be partly confirmed. The sample size in the TRITON trial is not so big. There were 84 patients enrolled at data cutoff, but still it is confirming what we found previously. And Dr. Skoulidis, interestingly, have published a paper in Nature in 2024 providing some mechanistic explanations about the role of dual immune checkpoint inhibitors in this tumor harboring STK11 or KEAP1 mutation. It seems that dual immune checkpoint blockade can improve the activation of CD4 plus T cells and reprogramming the myeloid compartment towards a tumoricidal phenotype. So something very interesting, the PFS was still blinded at the cutoff, so it was not presented here at ASCO, but I'm eager to see what are these results also in terms of PFS.